development also of products. So I will. So as you see, we'll made translation in Russian, and I will talk in English because I am, of course, obviously, I am not able to talk anyway in Russian. So, vitiligo, as you know, is a chronic acquired pigmentation disease, and the characteristics of vitiligo are white asymptomatic macules with demarcated margins on the skin, and this is the worry of the patients, you know, and this is the reason for which the patients are consulting a dermatologist. The word vitiligo is a very ancient word. It's coming from Latin, and the first to use it was this gentleman. You can see him on the picture. His name is Celsus. And during the 19th century, the clinical symptoms of vitiligo were precisely described in France by Brock, and also in Austria by Kaposi. And since then, there was no big change in the clinical symptoms of vitiligo. Vitiligo is the most frequent disorder of pigmentation. It's told to be, if you read publications, you can see that around 1% of the population worldwide has vitiligo. But honestly speaking, and being very close to this topic, I can tell you that probably it's more than 1%. And in some countries with dark skinned people, like in India, it can be in some regions till 6 or 7%. Vitiligo is affecting both genders equally, and in 70 to 80% of cases, vitiligo is occurring before the age of 30. And in almost 40% of cases, before the age of 12. So it's a disease which is occurring quite often in young children. And many times we think as dermatologists that vitiligo is not a severe dermatological disease because, of course, it's not contagious, it's not painful, it's not itchy, it's not worrying the people in terms of symptoms, it's not life-threatening, you cannot die because of vitiligo, but for the patient, it's completely different. Because for the patients, there is a very strong importance of vitiligo, which is affecting the well-being and self-esteem. And this makes the patients predisposed to social isolation, to depression. There is a very high percentage of depressed patients in vitiligo patients, and they have usually problems in sexual behavior and sexual relationships. And I was talking about India because I know very well this topic in India. And you know that in India, a girl with vitiligo cannot get married. So it's affecting very strongly the patients. And never tell the patient it's not a severe disease. All the contrary, we have to be psychological support for the patients. And as you can see, it's much more obvious, of course, in black people or dark-skinned people. And now about classification of vitiligo, it's clinically divided in two main forms: segmental vitiligo and non-segmental vitiligo. And in non-segmental vitiligo, there are three major subtypes: generalized vitiligo, acrofacial vitiligo, and universal vitiligo. We will check this, and you see that segmental vitiligo usually features like only one lesion. It can be extended, but usually there is no more than one lesion, and this lesion very often is located on the way of a nerve. So this is quite easy to diagnose. And non-segmental vitiligo is different in that this is not a unique lesion, but various lesions. And you see that now the subtypes, acrofacial vitiligo is affecting the face and the extremities, hands and feet. And generalized vitiligo is affecting any place, any location on the body. And finally, universal vitiligo is a word describing more than 80% of the skin surface affected. And you see in the case of this lady, obviously, we shall not use any treatment to repigment the patient, but on the contrary, we'll use a depigmentation treatment in order to remove the rests of pigmentation. And this is also, I know that in your countries, you have very fair skin, you know, and sometimes you cannot imagine what's happening in the places where people are dark-skinned individuals. And in this case, sometimes when we have to announce and to inform the patient that we have to remove all the remaining pigmentation, it's very difficult to accept because they are losing something from their ethnical properties and patrimony, you know, and it's very difficult sometimes to accept the people that they will be white once they were black-skinned before the disease. So this is etiology of vitiligo, and you can see that, let's see, you can see that there are three big groups of etiological factors. The first one are genetic factors. And you know that in some families, many people have vitiligo, and this is because of genetic background. And right now, we know more than 200 genes which are involved in vitiligo. So this genetic factor. Second one is immune factor, you know, and really vitiligo is autoimmune disease, as you know, and for this reason also it's very often associated with other autoimmune diseases like thyroid diseases, like Addison disease, or like even type 2 diabetes. And the third category of causative factors of vitiligo are free radicals. You know that the role of oxidative stress in vitiligo is very important. Now we'll talk about the treatments. And first, we'll talk about classical treatments. You know, we know about them for sometimes many years. And what we must remind at the beginning is that the first aim of treatment is obtaining skin repigmentation. And this is why we treat the patient, because as you know, it's a chronic disease and there is no cure for vitiligo. We must only, let's tell, avoid the patient keeping these white spots, white macles, and we must try do our best to repigment these white spots. Topical corticosteroids, they are considered as the first line of treatment. And why? First, because of their efficacy in vitiligo, but also because of large availability and also low cost. So vitiligo is the first line of treatment. And since they appeared on the market, I mean in 2000, something 1995 or 2000, we used to prescribe topical inhibitors of calcineurin. And we have mainly two products in this category, tacrolimus and pimecrolimus. And without giving you many details of literature and so on, because there are approximately 10 or 12 studies about efficacy of tacrolimus and pimecrolimus, and tacrolimus is more efficient than pimecrolimus. Topical analogues of vitamin D I think it was also by the beginning of this century, some colleagues tried to use calcipotriol in vitiligo, and it was a failure because calcipotriol and globally speaking, topical analogues of vitamin D are not active on vitiligo. Now, analogues of prostaglandin. And here we have some activity and good activity. The first one was prostaglandin E2. A gel was made with this active ingredient, and it was used twice per day in patients with vitiligo. And among 56 patients, there was complete repigmentation in 14% of patients, and satisfactory repigmentation higher than 75% in 22 patients, or almost 40% of the group. And this was after 6 months. It's not bad. It's quite a good result. And of course, other analogues of prostaglandin were tested, like latanoprost. The concentration is 0.005%. You know, it's an ophthalmological solution because ophthalmologists use it for glaucoma. And it was used for 6 months in topical application, once a day. And it was better in terms of results than placebo, and repigmentation higher than 50%. It's told to be acceptable repigmentation in 43% of cases. And this was comparable to narrowband UVB, in order to give you an idea. And you see that combination of latanoprost and narrowband UVB was, of course, better than narrowband UVB alone. And we had 62% repigmentation after 6 months. And the last analogous of prostaglandin, which is used by ophthalmologists and tested in vitiligo, was bimatoprost, 0.03%. Twice per day, and pigmentation, satisfactory pigmentation was observed in half of children, and this after 3 months. it seems to be quite a good result and a quick result. The only bad thing is about the small numbers of people in this test. Well, now you know about it because they were launched 20 years ago, something like this, topical antioxidants. And Colucci and a group of Italian colleagues reported that antioxidants may be used with benefits in association with other therapeutic options. And in this way, I was part of the study. We made a double-blind randomized study between betamethasone 0.05% and combination of superoxide dismutase and catalase. Twice per day about application of both products. And at 8 months, we had quite similar results in both products. But as you can see, the level of repigmentation was not very high. We had only 18% with betamethasone and 12% with antioxidant combination. Well, we have, as you know, and you have it also in Ukraine and in Russia, you have very nice atlas of dermatology, ancient, and this is from Bazin, the French one, in 1862, and with very good description of vitiligo. Well, now we finished with topical treatments, with classical topical treatments, and we start with physical treatments of vitiligo. And of course, all of you know about phototherapy. And now there are 3 major types of phototherapy for vitiligo, narrowband UVB, and phototherapy with UVA, and even what we name PUVA, which is combination of oral psoralen and UVA irradiation. But now, after many years and many studies, we can consider that narrowband UVB, mainly 311 nanometers wavelength, is the most efficient and safe therapy for vitiligo. If we have to choose, if we have all devices, narrowband UVB 311 is the best way. Another possibility, another option are lasers. And Excimer monochromatic laser is the only one to be approved by US FDA in vitiligo. And used alone, it permits satisfactory repigmentation in 20 to 29% of patients, depending on the duration of the treatment, of course. And it's important to know facial areas are giving better response than acral areas. Another laser which was tested is helium neon laser, and it was tested in segmental vitiligo with sessions every 2 weeks and moderate pigmentation, acceptable repigmentation in 60% of patients after 16 sessions. 16 sessions are 8 months. So it's a good result after 8 months. And now surgical treatments of vitiligo. You know that sometimes we have to use surgical therapy, which is useful in patients where medical therapy has not given results. You know, it's not first line treatment, it's not first line therapy, but only when we had some intense with medical therapy and even physical therapy, even narrowband UVB, we have no result. So we can test and try surgical options, but only when patients have stable vitiligo. If they don't have stable vitiligo, forget it, because you will have partial results and not good results, and the patients will not be satisfied. There are various surgical techniques, like injection in blisters, which is the most common, split thickness skin graft, punch graft, and transplant of autologous melanocyte suspension. This last option, transplant, is giving good results, but it's quite difficult to perform. First, you must be very well trained for this, and second, you must have some equipment for culture of melanocytes, and this is not very easy, and this is also quite costly for the patient. Now about systemic treatments of vitiligo. And this is the same, it's not first-line treatment. We only talk about systemic treatment when the first-line one is a failure. And this one consists of systemic corticosteroids. And the best way to use it is this one, dexamethasone, 2.5 milligrams per day, 2 consecutive days, and every week the same. Only twice per week, 2 consecutive days, 2.5 milligrams dexamethasone. And this is mini pulse therapy. This is the name, this is the word, and you can see that it's able to stabilize the disease in 92% of patients. And only after 13 weeks of treatment, which is a short time, you know. And all patients had some kind of repigmentation, and recurrence, this is important, recurrence after 1 year was only 12%. And side effects, of course, little high, 9%, but everybody knows that chronic treatment with corticosteroids, with systemic corticosteroids, is leading to side effects. And another test was with the same kind of mini pulse therapy with methylprednisolone during 6 months in children. And the results were comparable in terms of efficacy. We had like 90% of repigmentation of patients with repigmentation, and 35% of recurrence. But I think it's normal. You know why? Why do we have the big difference between the groups? Because in this one, we had patients from any age. And in this one, only children. And children have usually more rapidly evolving vitiligo. And this is why after 1 year, there was recurrence and more than in this group. Besides systemic corticosteroids, we can use azathioprine, 50 milligrams per day, 6 months, in combination with Puva. There was a test about this. It resulted in 58% repigmentation versus only 25% with Puva alone. So azathioprine may help in repigmenting the patients. And another very good drawing from vitiligo, it's from Cazenave. And now I think it's the most interesting part of this lecture. We'll talk about new treatments, about emerging treatments of vitiligo, because until now we talked about classical treatments. Everybody knew about this. Now we can talk about emerging treatments. And the first one is minocycline. Minocycline is used not as antibiotic, of course, obviously, but as immunomodulator and anti-inflammatory. We talk about 100 milligrams per day during 6 months. And in this case, we can get a stabilizing effect similar to corticosteroids in mini-pulse therapy. But there are also side effects like pigmentation of nails, skin, and mucous membranes, photosensitivity, nausea. We know about this side effect of minocycline when we use it in other diseases. Methotrexate may also be a good option, 10 milligrams per week, and the efficacy is the same as dexamethasone 5 milligrams per week in millipulse. And there is a good tolerance, but take care about hepatic toxicity. It may be hepatotoxic, and you must monitor hepatic function. Don't forget. Another emerging treatment is cyclosporine, which is a calcineurin inhibitor, and the dose is 3 milligrams per kilo per day during 3 months. And there was test about it with a significant reduction of VASI, of vitiligo score, and with very good tolerance. Cyclosporine in some recalcitrant patients may be a very good option. Another one is tofacitinib. This is a YAG-STAT inhibitor, and they made a study with 9 patients, and all of these are recent studies, you know. 9 patients with 10 milligrams per day plus narrowband UVB. And in the second group, 58 patients with only narrowband UVB. And at 8 months, it's quite a long period, repigmentation was 92% in the combination group versus 77% with only narrowband UVB. So it looks that tofacitinib may help, but it's not so active. And they also tested topical tofacitinib plus narrowband UVB, and the reduction in this case was 70% after 2 to 4 months. It seemed to be more efficient as a topical treatment than as a systemic. And importantly, the result was more rapid. Another YAG-STAT inhibitor is ruxolitinib, and a cream with 1.5% ruxolitinib was used twice a day during 20 days with good results on the face. You see, the results are very good on the face, but not so good on the body. And there were side effects like slight erythema, and more important acneiform eruptions and worsening of acne in case of patients with a combination of acne and vitiligo. And you can see these are pictures from the study we mentioned with ruxolitinib as a topical treatment, and you see that in some cases the results were interesting and acceptable for the patient. Well, statin inhibitors, statins were also tested, and why? It looks very strange, you know, and it makes no sense. but some French people, French colleagues, find in a man with treatment with simvastatin for cholesterol, they found repigmentation of vitiligo by chance. So they made a study with 15 randomized patients with 40 milligrams simvastatin per day during 1 month, and after 80 milligrams simvastatin per day, 5 following months, and this was versus placebo. And in the treated group, there was an increase. You can consider this increase of 26% in the treated group. So it's not only it's not efficient, but it's worsening vitiligo. Don't prescribe statins in vitiligo. And even in the patients with vitiligo, a cardiologist must be cautious about this, you know, and if they can avoid statin treatment, it's better for the patient. And further side effects, but everybody knows about this, myalgia, diarrhea, headache, and vertigo, they are common side effects of statins. Well, this is a very new product. This is alpha-melanotide. Alpha-melanotide is analogous of alpha-melanocyte stimulating hormone. You know, this is a substance which is able to stimulate the melanocyte in order to boost melanogenesis. It's working exactly like alpha-melanocyte stimulating hormone. And there was a clinical study, of course, 28 patients were randomized with monthly subcutaneous implant of 16 milligrams of alpha-melanotide plus narrowband UVB, and 27 patients with only narrowband UVB. And you see that the combination treatment was superior to narrowband UVB alone. And this was in on a duration of 6 months. And interesting results were more satisfactory in face and hands, but no results in feet. But you know very well that feet are a very bad location for getting results in vitiligo. And a few adverse effects like erythema, nausea, and generalized, this is maybe the most critical, you know, generalized skin hyperpigmentation. And really the people, when they finish the treatment, are tanned, you know, like when we are going to the beach in summer, they get sun tanning, and some people don't like it. And being sun tanned all over the year, for some people, it's not acceptable. And this was also an emerging treatment more than 1 century ago. You know, it was the first treatment of phototherapy in the world. It was in Copenhagen, in Denmark. And this was a treatment of lupus in this case. And this colleague, Dr. Finsen, was the one who created this phototherapy. He's the father of phototherapy. And he got the Nobel Prize in 1903. And unfortunately, he was so sick, he was not able to go to Sweden, to Stockholm to receive it, and he died in 1904. And he was the only dermatologist to receive a Nobel Prize in Nobel Prize history. Well, other emerging treatments in vitiligo, and now we focus on physical treatments. Bioskin is a focused microphototherapy device with a narrowband 311 nanometers. You know, it's like improvement of narrowband UVB 311. and 360 patients treated with Buirskin alone or with a combination every 2 weeks for 6 months. Satisfactory repigmentation with Buirskin as monotherapy was 72%. It's working very well. And the combination treatments are working better, of course, and combining Buirskin with betamethasone 0.05%, it was possible to achieve 90% of satisfactory repigmentation in the patients. So Buirskin is a good alternative. Laser Albas 355, because of wavelength of 355 nanometers, 1 session per week, 6 months, and 81% of patients after 6 months had satisfactory repigmentation. Fraxel erbium laser is also a good option, but not alone. You see this protocol, which is giving good result. It's a unique Fraxel erbium laser pass, followed by application of latanoprost, and the following day, 20-minute session of laser Albas 355. And you have to do it every 3 weeks during 9 months. And satisfactory repigmentation was obtained in 90% of patients. If you have the lasers at hand, it's a very good protocol. Titanium sapphire laser 311, you know, like narrowband UVB, per week with combined application of tacrolimus ointment twice per day, and 79% of patients had pigmentation higher than 75, and the average time was 10 weeks. It's a short period, you know. 10 weeks is 2.5 months, and for getting such a good result, really it's a good result and quick result. Other emerging treatments, mofetyl mycophenolate. There was a test in 30 patients treated with mofetyl mycophenolate 15% twice per day during 3 months. And there was very minor efficacy, and only 36% of patients have a mean repigmentation of 25%. There was no side effect, but not so much efficacy. And basic fibroblast growth factor, a decapeptide related to basic fibroblast growth factor, it was used in 2 groups of patients. One was treated with narrowband UVB alone, and the other one combination of narrowband UVB and this decapeptide. And what happened? The combination treatment resulted in 30% repigmentation versus 8% with only narrowband UVB. It's better combining narrowband UVB with decapeptide related with basic fibroblast growth factor, but you see that the result is not spectacular. So now the doctor, I can imagine that after hearing so many things, maybe she learned many things, but she doesn't know how to behave with vitiligo patients. And this is a very good algorithm, you know. And when you receive for the first time vitiligo patient, you must first determine if this is segmental or non-segmental vitiligo. In any case, and this is very important, you must explain about camouflage. Of course, camouflage will not cure vitiligo, but it will improve symptoms of vitiligo. Why is the patient, is she coming to see you? Because she has white spots and she wants to make disappear these white spots. And camouflage may be helpful, and you must propose it, and you must also teach it how to use it, because it's not easy. And especially when you are teaching to men don't use to use makeup, and you have to teach how to use it with satisfaction. And also, very important is psychological support. And I think that very often we should offer it to the patients, because as we told it, patients are suffering about psychological symptoms. And so, if this is segmental vitiligo, you are in early phase with active vitiligo, you must propose topical treatment with topical corticosteroids or topical calcineurin inhibitors and targeted UVB. This is the best treatment, you know, in first-line treatment. If the patient has already segmental vitiligo for some time, it's stabilized, then surgical treatment will help, because it will permit long-term repigmentation. In non-segmental vitiligo, this is the same thing. You know, you can have, during the first stage, rapid disease progression, and you can use, in this case, to stop this progression, oral mini-pulse steroids. This is the best way. And if this is already stable non-segmental, the same treatment with topical corticosteroids or calcineurin inhibitors and targeted UVB. And if you can not get a good response, but you are getting stability after 1 year and no Kemmer's phenomenon, surgical treatment will be permitted in this case. So this is, I think, the best algorithm, you know, for the management of a patient with vitiligo. So we'll talk about a new product that we are launching this week. You are the first ones to be informed about this. What is the purpose, you know, when we want to develop a new product for vitiligo? Which will be the key strategies? Well, the first one will be to favor regeneration of melanocytes and melanogenesis. As you know, there is a lack of melanocytes in vitiligo lesions, and we must increase the number of melanocytes, and of course, stimulate melanogenesis by these melanocytes. We must also focus immunotherapy, and we must try to interfere with cytokines functions and pathways, and stop, you know, in vitiligo, I don't want to insist on this, but there are a lot of growth factors and cytokines and pro-inflammatory factors which are increased, you know, in higher level, and then we must reestablish normal levels. And finally, also focus on oxidative stress using antioxidants. And we must not forget that we must act on various factors, as vitiligo is a multifactorial disease, and we cannot, and this is why combination treatments are giving better results, you know, because we have many factors in this disease. And if we are able to act on various factors and not only on one of these, we'll get better results. Well, when I developed it, my idea was this one. The first thing we told it, favor regeneration of melanocytes, and then increase stem cell factor expression, you know, and if we are increasing it, we'll have a higher number of stem cells, and we must try to get them oriented to specialization to melanoblasts and melanocytes. And we must also increase basic fibroblast growth factor expression and the number of keratinocytes and their stimulation. It may look strange, you know, because you'll tell me, well, keratinocytes, but they don't produce melanocyte, obviously. Sorry, they don't produce melanin. For producing melanin and repigmentin, you need melanocyte, but you know that there is a very special crosstalk between melanocyte and keratinocyte. And if you are improving the condition of keratinocyte, you will improve the condition of melanocyte. So we must keep them in mind like really a good assembly, you know, of cells, and we must always consider that they are both together in their function. And second thing I told you was interfering with cytokines. And we must reduce the levels of TGF-beta, transforming growth factor beta, of tumor necrosis factor alpha, of interferon gamma, and pro-inflammatory cytokines. And we must stimulate melanogenesis. We must stimulate WNT beta-catenin pathway. And this is a newly discovered pathway, and I will explain in a few words. You know that in the palm of hands, we don't have melanin. And this is the same for the sole of feet. We don't have melanin. Even African people have white palms, you know. And why? Because we have no receptors of WNT beta-catenin. And this is why there is no pigmentation. And this pathway, WNT beta-catenin pathway, is absolutely obligatory for melanogenesis. And the same about melanocortin-1 receptors, you know, we need them, and they must be functional if we want to have satisfactory melanogenesis. We must also stimulate cyclic AMP pathway, because even if there is no functionality of melanocortin-1 receptors, we can get some melanogenesis acting directly on cyclic AMP pathway. And finally, the microphthalmia factor, you know, we have it's reduced in the vitiligo lesions, and we have to restore physiological levels. And finally, this is the fight against oxidative stress. We must inhibit nitric oxide levels. And these are the two plants. The product is VITILSI, is a gel, and they are two plants in combination in the composition of the product. One is Coleus forscolii, and we are using root. And the second one, we are using leaves of Cassia alata. This is the composition of the product. And you can see, strangely, it's in Spanish here, so I will translate it, you know. You see, Coleus forscoli has many different activities, and it can increase expression of stem cell factor and basic fibroblast growth factor. It can increase the number and stimulation of keratinocyte. It will stimulate WNT beta-catenin pathway. It will reduce the levels of TGF-beta, TNF-alpha, and interferon gamma, and also reduce the levels of pro-inflammatory cytokines. It will inhibit production of nitric oxide synthase. It will increase expression of melanocortin-1 receptor and stimulate CAMP pathway and restore physiological levels of MITF. It will do almost everything, you know. And cassia alata is the only thing that Coleus cannot do is stimulate conversion of melanoblasts to melanocytes. And cassia alata is able to do it, you know. We have more stem cells thanks to Coleus, and cassia alata will transform these stem cells to melanoblast and active melanocyte. And besides, it has some anti-inflammatory properties also. And last thing, you see, pH 6.8. What does it mean? Usually, we are always talking about physiological pH of the skin, which is 5.5, and this is right, you know, for normal skin, we have to use cosmetics with pH 5.5. But if we talk about stimulating melanocyte, the best pH for melanocytes is 6.8. And it must be like very close to neutrality. And in this case, the melanocyte will produce more melanin. He will be more efficient. So we made a cream with pH 6.8 for this reason. We made a clinical study about efficacy and safety of VITILSI Gel. And this was made by really Master of Dermatology and the Master of Vitiligo, Professor Torello Lotti. We took 40 patients, 23 females and 17 males, age between 18 and 49, normal blood examination, vitiligo extension between 8 and 14%, and we excluded patients with vitiligo affecting only hand and feet, because you know it's very complicated to treat them and no need to oblige these people to a new clinical trial. And of course, all systemic and local treatments were prohibited during the study and stopped 10 weeks before starting the trial. Treatment for 8 weeks, 10 patients treated with Buirskin, you know, we talked about Buirskin, narrowband UVB 318, once per week during 8 weeks. 10 patients treating with VITILSI Gel alone, twice per day, 2 applications per day. 10 patients treated with combination of VITILSI twice a day and narrowband UVB 318, and 10 patients with placebo. It was a vehicle of the gel, you know. And photo evaluation in daylight and in wood light at baseline and after 8 weeks. You see the results. UVB alone, 28% repigmentation. VITILSI alone, 19%. And combination VITILSI and UVB, 41%. So we have a very potent product, you know, because alone in 2 months, it will permit 20% repigmentation. And combined with narrowband UVB, it will permit more than 40%. And you see, this is illustration of these results. No side effect, it's very important to see, because sometimes there could be a burn or itching or erythema or something like this, but we had absolutely no side effect. And if we check, if we compare, you know, with UVB, I took a few studies with UVB 8 weeks, published studies, and these are the results. And this is the average. And you see that VITILSI alone has absolutely the same efficacy as UVB alone. This is literature for these studies mentioned. And I compared VITILSI versus other topical treatments. And you see betamethasone has, I mean topical betamethasone, has the same efficacy in 8 weeks as VITILSI. Clobetasol is more efficient, but we know that we cannot use clobetasol during a long time in vitiligo. And tacrolimus, we talked about tacrolimus. We took available studies. This is the average, and you see that this is online. The efficacy of tacrolimus is online with the efficacy of VITILSI. These are references of bibliography. And now I must tell you thank you very sincerely, because I was very happy to be able to bring this data, and that you are here, you joined us for receiving this update. And I think that now Martin maybe can make a test with Katerina. Maybe Katerina fixes the problem. On the contrary, I would go to your questions and reply your questions. Of course, very well.
Excellent. Коллеги, если меня слышат все, пожалуйста, пишите вопросы для профессора Дила в чате. Я постараюсь перевести. К сожалению, по техническим причинам мне не удалось начать конференцию вместе со всеми. Также, пожалуйста, все участники, напишите свои имена. Я не вижу всех зарегистрировавшихся на конференции. Для подготовки сертификатов мне нужны полные имена участников. So we are waiting for questions. And I see only one attendance who told that. Just represent themselves. We are waiting.
Is there any question?
We are waiting for questions. They say thank you. Familidine is only available in subcutaneous implant form. It's Martin who told us. I don't see questions for now. Let's wait a few minutes.
And you know what? Maybe I will give you an email address. It's info@
Maybe will be good.
vitiligo.com.
I have one question. Just a second. Which combordarin, just a second, I lost it. Combordarin styles can be observed in vitiligo?
I didn't, it was interrupted. Can you repeat it?
Combordarin state can be observed in vitiligo patients?
You mean
combordarin styles, which types can be observed in?
Which types? Mainly two different types are segmental and non-segmental. And the difference is that segmental is only one spot, you know, only one macle. And non-segmental are more than one macle. And in this case, you have acrofacial, which is affecting the face and extremities, hand and feet. And you have generalized, which is affecting any part of the body, you know, it can affect any location. And finally, universal vitiligo, when more than 80% of the body surface is affected.
Let's wait a few more minutes, and if so, I will leave you email. Does thyroid disorders can lead to worseness of vitiligo?
You mean about diet, no?
Thyroid disorders. Thyroid disorders.
Yes, yes. It's quite common, you know, because both thyroid disorders and vitiligo are autoimmune diseases. And it's quite common to have association of both of them. But it doesn't mean the meaning of this, you know. First, when you see the patient, you have to check about this, you know, and to check with endocrinologist, because maybe the patient is not aware about this, and you have to teach the patient. And a second thing, if you are treating a metabolic disorder and thyroid disorder, it will not treat vitiligo, you know. It's an association of two diseases, but treating one of them is not improving the other one.
Another question from Irina. Do you have some, wait a second, I lost this question again. Do you have an experience with the treatment of depigmented hair in vitiligo?
Yes, I already did it. And you have to use derivatives of hydroquinone at 10%.
Ирина, вам нужен перевод или понятно? Ирина Бабак, отзовитесь, пожалуйста. Нужно переводить?
You know it, Katerina, you know it in France, I don't remember, is monobenzyl fer of hydroquinone, 10%. I don't remember the commercial name. You know?
I see. Can you repeat, please, your answer, because Irina needs a translation, so I will translate your answer for her about the pigmented hair.
Yes, you can do it with this derivative of hydroquinone.
Да, derivative гидрокинон. Есть у профессора опыт. Repeat again, please. Опыт есть.
You must do it in various sessions. You know, you cannot depigment the complete body in one session. And usually you have to sometimes to repeat it one or twice, but don't make the sessions very close, you know, because it's irritating, and give some time to the patient to recover. And for instance, at least 2 weeks time between two sessions.
Ага. Значит, между двумя сессиями лечения недели 2 перерыва для того, чтобы не вызывать раздражение, и 10% you told me, yeah?
Yes,
В
absolutely.
10% данное лечение.
In contact with the participants, you know, and you
I
ask
will
the
check. I will translate name of your Spanish webinars, and will ask people what they're interested to hear about. Actually, as for me, about superoxide dismutase and COVID, it would be very interesting. I promise you to make a Russian translation, so we can try this.
I will do it with pleasure. And what's about the situation? Are you still in confinement or something like this?
Situation is a bit better now. Our quarantine is not so strong for now, but university is still closed. We work in the distance. And in infectious disease department is still full of pneumonia patients.
So my question, Katerina, was because in this situation, maybe it's good to have one webinar weekly, no?
Yeah, and I see Tsira from Georgia also in our lecture, so I think for them it will be interesting as well too, because they had experience with it.
Tsira, and I tell hello, Tsira.
Yeah. She's here. I just saw her in our lecture. We can do it, because in case it's in my pocket to finish a translation of this lecture, and we can try to organize it at any time you can.
And what you could do with our participants is asking about the right time also, if they are happy with this time or a different time.
You see, we will do it. We had more than 150 registered people, and during the lecture, when I finally stabilized problems with my sound and my computer, I have seen only 50. So some people were lost, maybe because of technical problems. It's the internet, so
maybe
we can do
usually,
nothing.
Katerina, these Spanish webinars, we have between 300, 500 people every time. So they can enter, but maybe it depends on the local conditions of technical conditions. You saw that it was quite difficult for you to enter.
Yeah, we will fix it. Еще какие вопросы? Значит, мы создадим группу Viber. Я сейчас попрошу, чтобы Ксения помогла мне со всеми участниками. Мы создадим группу в Viber по вебинару. Мы вместе с вами выберем, я напишу, переведу, какие вебинары на испанском, на английском и на французском сейчас читает профессор для других стран. И мы выберем с вами вместе, что бы мы хотели услышать в ближайшие дни. И мы можем организовать еще одну лекцию. Есть достаточно интересные лекции, которые было бы интересно услышать. Но вот для всех участников, безусловно, тоже с сертификатом. So I translated to everybody, and let's wait a little bit because I have to collect all people, and then we will.
Okay. So we'll finish the meeting, and I will thank you very much, Katerina, for your help.
Thank you, Christian.
And thank you to everybody. I was very happy to be in Kiev at least for 1 hour. And let's try to do it on regular basis, and maybe
we will keep in touch, and I will let you know in a few days about a theme of the next meeting, and then with the time we will choose together.
Okay, with pleasure.
Okay,
so
excellent.
Bye-bye, everybody.
Bye.